quickly review what we talked about last time, then we're going to press on and see how far we can get into this today. So we talked about last time, we talked about MA and what MA controls both in the tube, and once we have exposure, it's one of the factors that creates mass. So at exposure we actually get travel of electrons across the tube, but when we hit the prep button, we have MA. It's just a collection of electrons to create this space charge. We're heating the filament, getting ready to make X-rays. So with MA, we don't have exposure, we don't have creation of X-rays yet. It's just heating of the filament. So MA controls intensity. It controls the quantity of electrons that we create. Definition of an amp is there. The effects on all of this is nothing. So really, the only thing that MA with exposure time would create at exposure is the number of X-rays we create. Before exposure, it just creates the space charge and how big that space charge is going to be. So once we make the exposure, we press the exposure button, and then we finally get radiation creation. The electrons jump from cathode to anode for the time that we have set, right? So then we have mass, and our just taking the exposure time by itself. Most of the time we want short exposure times, but there are times that we want to have that, what we refer to as autotomo. So we want the motion to blur out something that's superimposing something else. Lung markings on a sternum, lung markings on a lateral T-spine, the jaw and a wagging jaw, right? So there are times that we want that long exposure time in order to give us time to blur those things out, but most of the time it's going to be short exposure time. If our mass gets too low, we potentially could introduce quantum model. I really think that that's kind of gone the way of the dodo bird. It's still testable, but I think our image receptors are responsive enough that you almost can't get too low of a mass unless you do something, unless you expose something really big with way too little mass, then you might, but within a reasonable range, you're just not going to introduce quantum model very easily anymore. But it's still testable. So what quantum model is just inadequate exposure, so primarily too low a mass. So exposure time times your MA gives you your mass, and that's once we apply the KBP and the electrons jump across the tube, we get actual exposure. So then we talk about reciprocity. Reciprocity is just give and take, and that's manipulation of MA in time to arrive at the same mass value. And mass should be mass. And understanding that there's a little bit of a variance with quality control. So sometimes our mass doesn't work out to be exactly the same, but in order for it to be inaccurate enough to cause us problems, it has to get pretty high, right? So a 30% change in mass is barely noticeable, even in the index number, and with digital processing, it's really not noticeable at all. It's not until we get to a point where our index number indicates either we double the patient dose or we underexpose the patient by, half as much as what we should have, that we would even consider repeating because of that. So law of reciprocity just means, again, give and take. A lot of different ways to get to the same thing. So since motion artifact is the main thing that destroys your sharpness of recorded detail and you can't control it, then it becomes an issue, right? So we generally want as short an exposure time as possible. So mass then becomes the number of electrons that actually travels from the number of electrons that travel from the cathode to the anode, directly impacts the number of photons we create. It controls radiation quantity, has tube current, beam intensity. It controls image receptor exposures, what we use to control image receptor exposure. So remember, you can use KBP, but that's not our primary control. So if you see control of image receptor exposure, your answer to that question is always going to be mass. Thank you. Mass. It's going to be mass. The only qualifier to that is that if you want to increase penetration and increase image receptor exposure, then you might want to increase KBP. So distance, we ran through the scenarios that make the statement that it's independent of tube current to be true, and that is if nothing else changes. And remember, each one of these, we start off with if you change nothing else, this is what happens. If you change MA all by itself, image receptor exposure goes up, patient exposure goes up. If you increase SID, and that's the only thing that you do, assuming that you're not phototiming, then you don't get any change in tube current, but you do get a drastic change of exposure to the patient and to the image receptor. So without those changes, we don't get any difference in emissions, and that's only if you change SID. It determines the intensity at the image receptor, and if you're phototiming, then it works basically the direct square law for you. The phototimers are just radiation counters. You increase your distance from 40 to 72 inches, then what you should get is an increase in mass by a factor of around 3 1/4, right? So you can test that in clinicals. You can make an exposure of 40 inches back up to 72, not on a patient, but anyway, back up to 72 inches, make another exposure, and you should see that in practice. All right, so then we talked about how much it changed. So we have two laws that regulate that, or that describe that. One is the inverse square law, and that's actually the law that tells you how much of a change that you're going to have with a change in distance. It's the inverse square law. So since it's inverse, one thing goes up and another thing goes down. So if we increase our SID goes up, then our radiation intensity at the image receptor goes down, and it's going to be by a square of the change in distance. And we talked about that. If we double our distance, then our intensity at the image receptor decreases by a factor of the square of that. Our distance change is 2, so the square of 2 is 4, right? So it decreases by a factor of 4. So that's an inverse square law. And if you go from 40 to 72 inches, that change is not going to be 4 because we don't double our distance. It's a change of 3.24, right? So we talked about how you spot the inverse square law questions on a test, and that is generally going to be exposure. It's going to be radiation exposure. It's going to be measured in milligray, rem, rad, something besides mass. So because of the inverse square law, because we lose exposure at the image receptor as we increase SID, we have to introduce the direct square law. So direct square law, or the density maintenance formula, is how much of a change in mass you need to compensate for that increase in SID. So you increase your SID from 40 to 80 inches, you lose your exposure at the image receptor by a factor of 4, so then you need to increase your mass by a factor of 4, right? It's the same law, it's just kind of flipped around. So how you spot those questions on a test is your technique at 40 inches was blah. How much mass do you need if you change your SID to 72 inches? That would be, you need to multiply it by 3.24. So if I gave you 2 mass at 40 inches, all you would do is multiply 2 times 3.24. So you come out to between 6 and 7, right? So yeah, between 6 and 7. So direct square law changes in mass, inverse square law changes in exposure, and it's usually dose, and it's a lot of times it's going to be occupational dose. So that's your dose. You're standing a foot away from the patient during a fluoroscopy exam, you're getting blank number of units per minute. You increase your distance by 1 foot, now you've doubled your distance, your dose goes down by a factor of 4. Right. So dose is what we're looking for. Oh, and I honestly don't think that there's any of these on this test, but when you're sophomores and we go back through this, you're expected to not just know this, but to be able to apply multiple things, okay? So it's just kind of a teaser for what you're going to see in your sophomore year. What you're going to see, you got to read the question, right? You can't just glance over the question and say, okay, I doubled, and look for your doubles, right? So what I'm going to give you then is, let's say you're your occupational dose of 1 foot is 2 units, 2 milligrade, whatever, per hour, okay? So what is your dose if you increase your distance to 2 feet? What is your dose for 2 hours worth of fluoro? So you're gonna have multiple things that you have to consider. So you increase your distance, then your dose goes down by a factor of 4, but you doubled your time, right? So you got to consider that as well. So you would have to do 2 things. You'd have to increase, compensate for the increase in distance, decrease your exposure to 4, or increase by 4, decrease your exposure by 4, and then increase by 2 hours, right? So you'd have to double it. So anyway, that's not this time, but when we go back into this in the fall semester, you'll have multiple things to consider. So direct square law looks like that. Remember that, if you're going from 40 to 72, it's again going to be 3.24. Look for those catch things for each one of those. And again, most of the time that you're going to make a mistake, it's going to be one of 2 things. You either forgot to square the change in distance, or you just went in the wrong direction. Remember, if you're looking for dose, you increase distance, you decrease dose. If you're looking for changes in technique, you increase distance, you increase technique, right? So then we talk about focal spot sizes, and this is what we use to control sharpness recorded detail, understanding that sharpness recorded detail is a product of a lot of different things. This is the setting that we use on the machine to control sharpness recorded details, focal spot size. The smaller the focus, the sharper the image, right? But we still have to consider things like OID, SID, image receptor issues that we'll talk about later in the curriculum. But in the X-ray tube, and what we use to control sharpness recorded detail in the system is your focal spot size. So we had a number of different types. We had general purpose, we had special procedures, which utilize what we refer to as a fractional focal spot. In memo tubes, we use microfocus tubes because we're looking for little bitty tiny things. So the filament size is what we're actually selecting on those. Remembering the tube output is not going to change between focal spot sizes, providing the machine will allow you to make an exposure, right? So most of your machines won't let you select small focal spot with an MA station above 200. Certainly not above 300, but probably 200 is as high MA station as you're going to be able to select on a small focal spot. So when you get to a question on a test, is this asking what should the difference be in exposure between large and small focal spot? Your answer is nothing. Mass is mass, KVP is KVP. As long as it allows you to make that exposure, then it shouldn't be anything. Now I might ask you a question. This says, what error might you get if you select 400 MA on a small focal spot, and that's going to be tube overload? You're not going to be able to make an exposure. Okay, so those aren't the same thing. If you can make an exposure, your exposure should be identical on a large and small focal spot. All right. So then we talk about filtration. We talk about inherent, added, and compensating filters. Inherent is anything that you can't remove from the system and still legally make an X-ray. So that's how we're going to define it for our purposes, and that would be the tube envelope, that would be the oil, that would be the port in the protective housing, that would be the backside of the mirror, and anything else that needs to be added to bring us up to 2.5 millimeters of aluminum. Remembering also that inherent filtration increases over the life of the X-ray tube because of tanning of the tube. And added filtration will be anything that you add above all of that, right? So even though tanning is added filtration, it's an added inherent filtration because you can't remove it. So could you go in and reduce, I mean, scrape some of the silver off the back of the mirror and bring it down to 2.5. Yeah, but who's going to do that, right? So just know that inherent filtration increases with the age of the tube because of tanning. You're not going to compensate for it. You're not going to remove some inherent filter, drain some of the oil out of the, protect. You're just not going to do it. All right, so added filtration is anything that you intentionally add that is not tanning, and that includes compensating filters. And really, compensating filters that you might visualize now are things like trough filters for scoliosis series, things like that. All right, so I don't think we got to the effects on the X-ray beam. I think that's pretty much where we left off, was it not? Okay, so the effects on the image quality. If you're in some of these Facebook groups, you're going to see some questions that ask you for the effects of KVP, mass, machine phase, filtration on your contrast or your density. And those things are really, if you look through the content specifications, especially on contrast, you don't see those on the content specifications anymore. They're still lingering around and people are still teaching this, but it's not really a thing anymore. It was a big thing in screens and films. It's just not really a thing anymore. So the things that really affect your contrast on your image are three things, and that is patient size, tissue density, tissue type essentially, and the computer algorithm that you process your image with, are the main things that are going to give you at least contrast. There are some things like if you leave your collimator open, you get too much direct exposure to the image receptor, and you have basically an error in the processing of that image, that could affect it as well. But assuming that you did everything right, really these things don't affect your image quality all that much anymore. Okay, so the effects on the image quality, really not. It doesn't really do anything. It's still very valid in understanding what it does to the X-ray beam. Doesn't do anything to the peak energy because that's just KVP, right? Doesn't do anything, well, it does everything else though. It is what determines what level our minimum energy is going to be. If you add filtration, more filtration above that 2.5, then what we're going to do is we're going to eliminate more of the low energy X-ray photons, and that brim spectrum is going to come off more towards the high energy side. So we're going to get rid of more low energy X-ray photons. That's going to push the peak of that bubble towards a high energy side, which increases the average. So I'll go back to test question analogies. So I give you 10 tests during a semester, and I drop the lowest test grade. What happens to your average? What happens? It goes up, right? What happens to the highest test score? Nothing. It just increases average. What happens to the number of tests? It goes down. Okay, so apply that to the brim spectrum. Our quantity goes down, our average goes up, and the minimum energy goes up as well. Okay, so we have a better beam. What you'll see and hear the beam referred to as average or KVP goes up is that it's a harder beam, okay? So it's a higher quality beam. KVP controls your quality, so even in the entire spectrum, if our KVP doesn't go up but our average increases, we still have a better quality X-ray beam. More likely to penetrate. Penetration equals quality. So it will affect our quality. So it doesn't affect our peak energy, it does increase our average, really no effect on contrast. The quantity does go down though. So if, let's say we make one exposure, and why we would do this, I don't have an analogy for this, but you need to repeat your exposure and increase your filtration. Same patient, you add more filtration. What's going to happen to the exposure at the image receptor? It's going to decrease. So if you had the perfect exposure on the first exposure, what are you going to need to do for the second one? Increase specifically, almost universally, unless the question is asking you for more penetration or to you know, to repeat but not double the patient mass, what are you going to increase? Mass. So you lost quantity, you need to reintroduce quantity. So it's going to be mass. You increase your mass, right? So whenever they do the annual inspection, you know, they come in, they make exposures. It's quality control again. They make an exposure. And last year, you know, they set a technique of 70 kVp at 10 mass, and they got, you know, it's at 70 kVp, your exposure to your mass in milligrams, milligrams is about 5 to 1. So it'd be like 50 milligrams. So this year they go in and they make the exposure again, and it's, instead of 50, it's 40. Why is it 40 this year as opposed to 50 last year? Well, there's the tanning of the tube, right? So we've got more inherent filtration. So what they're going to have to do is they're going to have to tweak it to bring, you know, that back up, that 10 mass back up to 50 milligram exposure. Okay. So effects on image receptor exposure does decrease it. Effects on patient dose, though. We have a higher energy X-ray beam, more penetrating X-ray beam. What type of interactions increase the patient dose the most? You got 3. Essentially, you get scatter radiation, which is partial absorption. You have penetration without interaction. You have total absorption. Which one of those 3 add most to the patient dose? Total absorption, right? So if your X-ray beam then is more penetrating, then what should your effect be on patient dose? Should go down, right? Should go down. So it's a better beam for the patient. Back in the day when we used screens and films, you know, it was hard. I don't want to confuse you, but it was kind of hard to keep this straight because beam quality goes up, but since penetration controlled our contrast, image quality went down. Okay, we really don't see that anymore because the main thing that controls your contrast now in the system is going to be the computer algorithm, right? All right, so along the same lines, the generation, single phase, 3-phase, what we're looking at here is how many pulses we're going to stack per second or unit of exposure within a specific time, right? So it's our voltage waveform, and our voltage waveforms look like that. So the first 2 you're just never going to work with most likely. If you do work with one, it would be that full wave rectified single phase machine. But those are going to be rare. You're probably never going to see one in a hospital. If you're working in a doctor's office, you might see them, and I say it's a very strong might. I think the demand for those is probably so low that the price difference between a full wave rectified and a modern machine, the price difference is probably evened out a little bit. I haven't priced these, so I don't know, but I would imagine you know, it's not that much more expensive to go with a modern machine as opposed to one of those. So if you work in a doctor's office somewhere, you might see full wave rectified. You're never going to see those. Okay. The only place that you might see a half wave rectified if you're sitting in a dentist's office and they're taking X-rays on you. You remember last semester we were talking about self-rectified machines, and it was just a very short description of what a self-rectified machine is. The self-rectified machine has no rectifiers. The X-ray tube becomes the rectifier, and they're low exposure, so the chances of that reverse flow of electrons that would damage the filament just isn't there. The only place we see that's in a dental unit, right? So you'll see them in a dental unit, but you're never going to use one. So how you keep these 2 straight is how much of the wave are you using if the wave goes up and it goes down? How much of the wave are you using here? Half, right. So if we flip that negative side that should be right there up and we use that, we're using the full wave, right? So full wave rectified is what you might use. 3-phase, we have 3 pulses that overlap every second. So what we get then is 100% voltage ripple, 100% voltage ripple. It drops to about 14% for 3-wave three-phase 6 pulse and three-phase 12 pulse, we get down to about 4%, and then high frequency, we get down to less than 1%. So very efficient. It's almost a constant tube potential throughout the exposure. kVp remains the same. So if what we're talking about here is peak voltage all the way down to no voltage, to peak voltage to no voltage, peak voltage to no voltage, both of these have 100% voltage ripple, but you get an increased output here. Right? So in these three, where does your voltage drop to 0? When you stop making an exposure, right? So it doesn't, right? So if the voltage never drops to 0, then this voltage ripple indicates the peak to the minimum voltages, right? So now, let's say, you know, you've got a whole semester worth of tests, and the only test scores that you have are 100 and an 86. What's your average? Yeah, that's a pretty good average, right? And then, of course, down here, if you know you're at 99 and 100, then your average is extremely high. So what happens when we change waveform? We go from single phase to three phase. Our average goes up. Also, we get an increase in the numbers, the output from the X-ray tube. So our bubble goes up and it pushes towards the high energy side. Now, you're going to have a tendency to kind of conflate filtration and machine phase, okay, because they have some of the same characteristics. With filtration, our minimum changes, right, but the maximum does not change, and the average goes towards a high energy side. But what happens with the numbers? We increase filtration, numbers go down, right? With machine phase, it shifts towards a high energy side. Peak energy does not change, but the numbers go up, okay? So how we would change our technique between a single phase and a three phase is that if we use the perfect technique in a single phase room, and then we use the exact same technique in a three phase room, then what's going to be the result at the image receptor? We get more penetration and more output. So what's going to happen at the image, just in a word, I'm not looking for a number, just in a word, what's going to happen at the image receptor? Too much, right? So it's too much. So if we change from a single phase room to a three phase room, then we have to change our technique. Specifically, what are we going to change? Mass, right? So mass. So if we go from a single phase to three phase room, we're going to change our technique. And if you remember from last semester, I'm not going to throw it out there and, you know, embarrass anybody, but you would think single phase to three phase would be a factor of 3. That would just make sense, wouldn't it? But no, it's a factor of 2, right? So once we go from single phase to high frequencies, about 2.5, right? So really, if you're working with three-phase 12 pulse and you switch over to high frequency, the amount of change that's necessary is so minimal that you could use the same technique in both rooms and not really see any effects on the image. But if you went from single phase to high frequency, potentially you could. All right. So what's going to affect your technique? Well, we've got patient factors, image quality factors, and exposure technique factors. Some of these things we're going to talk about in different, different chapters. Grids, for example, we're going to talk about those grids in different chapters, image receptors as well. So patient factors, anatomic thickness, and body composition, so 2 totally different things. With body composition, what we're talking about are different tissue types, and we'll talk about that a little bit differently here in a bit. But image quality factors, the sensitivity of the image receptor is big, so our type and the exposure that you need. Somebody said that we still have a clinical site that has CR capabilities. Is any clinical site using CRC tell CR because you have to switch out the image receptor.
We have a portable, but they don't really use it.
They don't use it?
Yeah.
Okay.
I think Cedar Creek has a portable too, that has, we don't use it.
Yeah,
But I think
Cedar
they
Creek
have-
maybe?
All their machines are CR turned into DR. Like,
Yeah.
They just upgraded, they didn't get anything new.
Yeah, they just added a
Yeah.
DR cassette, yeah. We'll run through that later in the semester, but CR cassettes are not as fast as DR cassettes. So CR is slower, and what that means is that you have to use more radiation exposure to get up to the proper exposure on a CR cassette. So, and that there's direct correlation between, they assign them numbers, and there's direct correlation between the numbers and how much of a change in technique you would need. For example, CR is 200 speed as opposed to DR, and films are both 400 speed. So what that means is that the exposure that you would use on a CR cassette, if you made that exposure on a DR cassette, it would be twice 200, 400. It'd be twice as much as what you need. Okay, so they also control our detail and then our orientation of our image, image receptors and our anatomy both can affect our distortion. But our technique factors and things that can affect the technique that we're going to utilize are the things that we've talked about, but we're also going to talk about grids later in the semester, when it's appropriate to use a grid, when it seems like it might be appropriate to use a grid, but it's really kind of optional, and how much of a change we're going to need in our technique to compensate for those. So in our patient factors, that's really where we're going to see changes in contrast on our image receptor more than anything else. So we've got two different things, and that is primarily body composition and body habitus. So where we've got body habitus, you know what the body habitus is, or body habiti are, but part thickness, independent of the body habitus, is really what affects the appearance of your image. So part thickness, what's the part made of? Is it primarily fat or muscle? Look very similar on the image receptor, as far as scatter creation goes. Is it bone? Is it air? What is the body composition? But that's not enough. The body composition, what it's made of, is not enough. There's a chart in Bushong's that goes through the actual atomic numbers of, or it's not the atomic number of the tissue, because where does fat fall on the elemental table? Where's bone? Where's muscle? It's made up of different things, right? So it's not just the tissue, but it's the compactness of it. And if you look at that chart in Bushong, what you'll see is that soft tissue and air, not lung, but air, are very similar. Actually, air is a higher atomic number, effective atomic number, than what is soft tissue. So why is it that soft tissue shows up so dark on the image? Why is it the air shows up so dark on the image and soft tissue is much less dark?
Just density.
It's the compactness. I'm straying away from density. You're right, it's density, but it's the compactness of it. Okay, so you can have things that look a lot alike that have greatly different atomic numbers, and therefore weight and likelihood of penetrability. Okay, so I'll use this example. How much does water weigh? Anybody know? It's about 8.5 pounds a gallon. Okay, oil, if you pour oil on top of water, what happens? It floats. It floats. So the oil is lighter than the water. Okay, and if you pick up 2 jugs of it, you might not be able to tell the difference. But we keep bees. We've got bees. We've had as many as 4 hives. We're down to 1 right now. A lot of things go into why you might lose bees, but this last year, most beekeepers lost most of their hives. It was a bad year for them. Mites and beetles and moths and all kinds of stuff we get into. So the first year that we extracted honey, took 5-gallon buckets and took it over to a friend's house. It's got basically a centrifuge that spins the honey out of the combs, right? So filled up a 5-gallon bucket, and I went over to pick it up. And so 5-gallon bucket, I'm expecting about 40 pounds worth of resistance when I go to pick it up. And I picked it up, and I thought, what happened to me? This thing is heavy. 40 pounds used to not be heavy. This is heavy, at least heavier than what I thought it should have been. So, okay, so take a brief detour from that. You observe oil versus water, and which one looks like it should be heavier because it has greater viscosity? Oil, right. So now you look at oil versus water and oil versus honey, and which one is more, which comparison is more similar? Oil and water or oil and honey?
Oil and
Oil and honey, both of them are thicker than water, right? Well, it turns out honey weighs in at about 11 pounds a gallon, all right? So when you're expecting to pick up 40 pounds and you pick up instead 55 pounds, you got 15 pounds extra there. I wasn't as out of shape as I thought it was. It was just that I didn't understand how heavy, the mineral content in honey was. So the moral of this story is, going back to last semester, we talked about the difference between lead and aluminum. You have a quantity of lead and a quantity of aluminum, which weighs more? If you have the same, let's say I've got this cup and it's full of lead, and then I've got another cup exactly like this and it's full of aluminum, which one weighs more? Lead, right. So, and that is because the construction of the atom is much more dense, okay? So with it being more dense and confined to a specific place, it weighs more, okay? So how compact is the air in the lung? And not very, right? It's all spread out. So another example is the difference in radiographic appearance of iodinated contrast versus barium. With iodinated contrast, you inject, let's say, a milligram or whatever. Can you still see the spinal cord through the iodine? Anybody done a milligram yet? Nobody's done a milligram. Okay. Anybody done any kind of contrast? Well, upper GI with iodinated contrast. You can see through the contrast. Anybody? Nobody. Okay, you will eventually. But barium, you just can't see through barium. It's just dense. But the atomic numbers are almost identical. So what's the difference? It's the quantity in suspension, right? So the barium is much more dense. So it's not just the atomic number or the effective atomic number, and that's what you'll see these referred to as, is effective atomic number, or Z effective, or ZEF number. Okay, what that means is kind of the average atomic number of all the mineralization in bone would be its ZEF number. Okay, so what's going to control your contrast then in your image is all those things. Okay, so it's going to be how much soft tissue are you going to put on top of that bone? How much scatter do you create in relationship to that bone? If you have somebody who's asthenic, you're going to have very high contrast as long as the bone is healthy. If you have somebody who's hypersthenic, your contrast is going to be decreased because of the scatter that you create. If you have somebody who's got osteoporosis, then what you've got is a loss of bone mineralization, and your contrast is going to be decreased, as opposed to if you have somebody who's got osteopetrosis, which adds bone density, is going to stand out a whole lot more. Okay, so the things that used to affect our contrast and our density on our image really don't so much anymore. You can affect those things, and primarily how you affect those things really, really screwing up your technique, or what you might get is if you undercollimate and you have a lot of direct exposure to the image receptor, your machine can't really figure out what you're doing, then you get an error in the reconstruction of your contrast. It can't figure out what you did because you got all this dark area. So collimation becomes as important to the image as it used to be in reducing scatter radiation, but now it's because of the the computation, the application of the computer algorithm to your image. Okay, so then pathology, and we just kind of touched on that. We've got two different types of pathology. One's additive and one's subtractive. So additive pathologies are pathologies that would add patient density, osteopetrosis. Destructive pathologies would be any kind of pathology that removes. So you got osteoporosis. All right, so you've got, let's say, you got a patient with healthy lungs versus a patient with massive pleural effusion. Additive, subtractive. Is it going to absorb the, is the pleural effusion going to absorb more x-rays? Yeah, so it's additive, right? As opposed to a pneumothorax. Now the lung is collapsed and all you've got is air and you don't have any of those lung markings at all. Is that additive or destructive? Destructive. Emphysema. Hyperinflation of the alveolar sac so that you've displaced some of that lung tissue and your alveolar sacs hold more air than what they should. Additive, destructive. Destructive. Okay. So all of those will affect the appearance of your image and could then affect your technique. So in pathology, it gets a little bit dicey. What technical factor are you going to change? Well, it depends, really. Most of the time, what we want to do is avoid creating more scatter radiation. So let's go back to the patient with the pleural effusion. What type of tissue creates more scatter radiation? Emits more scatter radiation, because scatter radiation, remembering from earlier, in this lecture series in KVP, it doesn't really affect it all that much. Less dense, specifically anything that's kind of like water, right? Well, what's a pleural effusion? Water. It's water, right? So what technical factor is going to penetrate more of that scatter radiation, KVP or mass? Percentage-wise, KVP, right? So what do you not want to do if you've added something that's more likely to what technical factor do you not want to use if you've added a pathology that would give you more scatter?
You don't want to increase your KVP.
You don't want to increase your KVP, you want to increase your mass. So probably 9 out of 10 questions that you will receive about technical changes for pathology are going to be mass, okay? And the answer to the question, how much of change is almost universally going to be 30 to 50% increase in mass. For an additive disease, 30 to 50% decrease in mass for a destructive disease. Now, if you have something where you've got an additive or destructive disease that added or removed bony tissue, now you got something different. Now you might need to, if you got a patient with osteopetrosis, Paget's disease, something that added a lot of bony tissue, acromegaly, you might want to increase your KVP in that case, okay? And KVP increase, if you're looking at a 30% increase in mass, that's roughly 1/3, right? One third of a doubling. Well, how much KVP does it take to double image receptor exposure? 15%. So what's 1/3 of 15%? 5%. So 5% change in KVP. When KVP, when you need to increase penetration, you have those additive conditions, specifically bony conditions, you might increase KVP by 15%, by 5%. You have a destructive disease like osteoporosis, you might decrease by 5%. Again, those are going to be outliers. 90% of your questions are going to be asking for changes in mass, and your answer is 30 to 50%, right? All right, so one thing that always trips people up is post-mortem films. Okay, so you're shooting post-mortem images on the patient. Does the patient have the disease? Well, sort of, you know. Is death a disease? I don't know. You know, it's the end result of a disease. But what you get in post-mortem images is the blood tends to settle in the great cavities, which is kind of like the patient having ascites. So what's ascites? A lot of water. They got a lot of water, right? So it's kind of like the patient having ascites. So if you walked into the patient's room, you knew the patient had ascites, and you were having to shoot an ankle on the patient, what would you do with your technique? Please don't butcher this.
Increase your mass.
Increase your mass by 30 to 50%, exactly. So you're doing post-mortem films, it acts like ascites. What would you do?
Increase your mass.
By 30 to 50%. Okay? All right, so that's technique as it is applied to, patient factors. Most of the time your compensation is going to be mass. So density is probably where we're going to leave off. Yeah, we got 5 minutes. Density. Make sure on your questions you're answering the right question or answering for the right density. There's 2 different densities. There's a radiographic density and there is patient density. Okay, so density is in both cases kind of the thickening of the how thick is something. You think of somebody as being dense, and I don't mean physically. You say, "God, that guy's dense." What are you saying? He's stupid. He's thick. Nothing gets through. So density applied to radiography is kind of the same thing. Is how thick is something? How thick is the darkening of the image versus how thick is the tissue type? Okay, so patient density is it's just that. It's how hard is it to penetrate through. So bone is more dense than soft tissue. Soft tissue is more dense than air. Right, so you're going to have questions that'll say, number or list the tissue types from least to most dense. Okay, even though the atomic number, the effective atomic number of air is higher, only barely, than soft tissue, it's still, because of how dispersed it is, it's still easy to penetrate, so it's not very dense, right? It's easy to penetrate because it's not very dense. It's not compact enough to absorb all those X-rays. So you have 4 types. You've got air, fat, soft tissue, and bone, right? Those are your 4 tissue types. And that's the order that they're going to go from least to most dense. All right, so radiographic density is how dark the image is, and it can be a specific area or it can be the overall image. If again you forget to collimate and half of your image is direct exposure to the image receptor, your computer algorithm, your applied computer algorithm, your computer doesn't know what you did. They think that you've got a pathology there that is just, it's too easy to penetrate. It's a very subtractive pathology, and it's going to adjust your overall density, and it's going to adjust your contrast. It's going to come out of potentially a bad image. So the area that got the direct exposure is going to be very dark, right? That's high density, very high density. So where you've got the lungs, a chest x-ray, that's high density. Mediastinum is low density, okay? The difference between those 2 densities would be what we call contrast, okay? So patient density, how dense is the structure? Patient density and radiographic density have an inverse relationship, okay? What's the most dense tissue type? Bone. Is bone. How does bone show up on an x-ray? Light. So high patient density gives you low radiographic density. Okay. Contrast again is the difference between those 2. The difference between what you'll see contrast description of contrast in a question would be the difference in radiographic density between adjacent structures, something like that. Okay, so density, how dark is it? Contrast is what does it look like compared to something else? You know, you're looking at black and white here, that's high contrast. If, you know, if I took this entire sentence and I went from, you know, the I being white to the Y being black, and each one was a little bit different, you know, increasing in density all the way until it got to the black one, then that would be those densities spread out over a very wide margin. That would be low density or low contrast, right? Between each one of those subtle differences. So if you have subtle differences in density, then what you have is low contrast. If you have very high difference, a lot of difference in density, then you have high contrast. Okay? So density. How dark is the image? How firm, how hard to penetrate is the structure? Okay? So any questions? Yeah.
Did you say high patient density is like the low radiographic density?
Exactly. So bone, high density, patient density is very, you know, light on the image, so it's low density on the image. Yep. Anything else?